Welcome back, everyone. Welcome to another virtual morning report. I'm Youssef, one of the team members. I'll be co-discussing today with Julia. Julia, I'm really excited to co-discuss with you.
I am as well. Hi, Youssef.
Yay, let's do it. Sime, do you want to say a word before we start?
I think we should start.
Yeah. I just want to go over the scribe and the teaching points. I don't know if you want to Sime
Everyone,
and
I'm just
Nicola.
excited for the started.
Okay.
Awesome. And Nicola, did you want to say a word?
Hi, hello, my friends. It's great seeing you all like once again, and I'm really excited to dive into this rich case, as I'm sure it will be a rich one.
Yeah, let's do it. And Ahmed, nice to meet you virtually. Do you want to just tell us about yourself, where you're calling from? How did you find out about CPS?
I'm a student from King Edward Medical University from Pakistan, and I got to know about CP solvers about an year ago on internet, and I was very much interested in presenting a case over there. Uh, when I got my rotations at Mayo Hospital, the greatest hospital in Lahore, I got a case and I shared that on social media platform of CP solvers. And fortunately, I was fortunate enough that my case was selected for a presentation. It's my first presentation, and I think I will continue to present other cases soon in this platform.
Yeah, that's so great. Anybody who wants to present a case, you can just go to our website and you can sign up there. It's clinicalproblemsolving.com and you can click on present a case. So that's awesome. Thank you so much for bringing us a case. So whenever you're ready, feel free to go ahead with the first aliquot. And Julia, we can take turns if you want starting and then we can alternate.
Yes, I'm ready. I think we can start. Uh, so here I would like to present this case. I will first present the aliquot one, and the case is a 36-year-old woman presenting to the clinic with weakness. She had been in her usual state of health until approximately 3 years ago when she began experiencing generalized weakness. Over the course of 2 years, she underwent multiple evaluations by local physicians and was treated symptomatically with multivitamins and analgesics for persistent bone pain. Then, 1 year ago, she developed a toothache accompanied by swelling in her left upper jaw, for which she consulted a dentist, underwent a dental extraction, and was prescribed antibiotics for what was presumed to be a cystic lesion in maxillary region, but that did not improve with the use of antibiotics. Now, following the extraction, her and her family also felt her left eye was more prominent and was sticking out. And, over the last 6 months in particular, she had developed significant bilateral lower limb weakness to the point she was no longer able to walk, uh, requiring family members to carry her. Given ongoing progression of weakness, she was brought in by her family to the clinic for evaluation. And it's the end of aliquot number one.
Okay, Julia, if you want to go first, just give like your impressions, what you're thinking so far, and what caught your eye.
That was such a phenomenal start, Ali. Thank you so much. So to summarize, we have a quite young female here, 36-year-old, and her chief complaint is weakness. And I think what we always love to do in CP solvers is thinking about weakness first of all, if it's like really weakness that can with a localizing sign. So like muscular weakness in a particular space, or rather like asthenia, so general weakness. And then of course it's very important to establish whether it's like the center of gravity in this case or not. But just to dive in a little bit, I think it's always good to emphasize and ask a patient in particular if there's like the whole body weakness, just or a weakness on exertion, that is always like a hint to cardiopulmonary disease or anything, or if you're also weak at rest. That is something I would really love to dive in, or if I can quantify the weakness. So, and then thinking about more the neuroaxis, and the lesion could be anywhere from the cortex to the muscle. But here I feel it's quite interesting that because you gave us a lot of background to the patient's history, and there's one complaint that I don't often deal with is toothache, to be honest, and that is something that that was apparently such strong that it led to tooth extraction. And that was just a buzzword for me, because always like if I think about like teeth extraction, also like kind of surgery, I think about at least a subtle bacteremia. That is something just have in the background that can be a risk factor for disseminated bacterial infection or even endocarditis. But also I think that is just a side note here. What's striking to me, and that's what you were asking, Youssef, is that she presented with lower limb weakness for the last 6 months. So of course I wanna quantify if it's like if there are like any associated symptoms. Is there also like a tingling if she cannot feel the ground, if it's like weakness and she cannot lift it? So I would like dive in a little bit further and specify how the weakness presents. But that is just something, because it's bilateral, I think it makes me a little bit less likely to be just like the neural lesions or something. For example, lesion in the spinal cord or something. Of course, I also, with lower limb weakness, I always think about like a nerve compression as well, and then I would really have to um, exclude like the pertinent negatives, like is there any like urinary bladder syndromes, anything, any reflexes that are diminished. So that is something I would love to assess. But I think it's such an intriguing start. There could be so many things going on at this moment. um, Maybe you can put some structure in this like diffuse, um, first impulse thoughts I
Yeah,
have.
no, I agree. Like, first of all, regarding the weakness portion, is like we need an exam and we need to see like how weak, if it's like actual weakness, if it's focal or is asthenia. The things that I wanted to comment on, the swelling on the face or the jaw, and then possible protrusion of the eye. This is really interesting because we had a case of lip swelling this morning. So we were like just discussing like what causes lip swelling, and a lot of times you consider whether this is angioedema or histamine related. If it is histamine related, you consider this is purely for lip swelling. You consider either anaphylaxis or an allergy. While if it's angioedema, you go down that pathway. You look for ACEs or you look for like an inhibitor of some sort. But this is here we hear that there's transient lip swelling, and then there is possible left eye proptosis, or at least her left eye is popping out. That's what I read. Is that right, Ahmed?
Yes, the eye was like sticking out. There was a cystic lesion in the left upper jaw,
Okay,
which was
okay.
confirmed to be a dental infection, but after dental extraction, it wasn't improved.
Yeah, yeah, and now we're considering, it's not just lip swelling, right? It's lip swelling plus another organ which is swollen, which is the eye, and this is where you have to change your schema because this is not just lip. This is like you might use your facial swelling script, and the question is this fluid? We didn't hear about lower extremity edema, probably not. The next layer is this something infiltrating into the facial structures? We already heard that there is maybe a cystic lesion there. The question is like what can infiltrate? We're really good at knowing this about thyroid disease, where it's like glycosaminoglycans, for example. We're really good at knowing like cancer can invade the lymphatics and cause like a partial like infiltration. And they're like rare diseases, but these would be like most common. Uh, how would I take this further? I think I want to look for the structures of the face. I think we're gonna looking for the exam. We'll get that information soon, and then we're gonna look for systemic clues around the body to see like what clues do we have, because I think the weakness is very profound, and I think that's what I'm taking from it. It's more than like a diagnostic value, more that this is a profound syndrome, and that's helpful that way.
Let me present the aliquot 2, which will be about the additional review of systems. Uh, Additional review of systems showed that she had a history of malaise and 5 kg of weight loss for the last 2 years. She also noted diffuse bone pain involving multiple areas of body, and she was unable to lie on the same side throughout the night due to onset of pain after a short duration, but had no associated trauma, swelling, or anything. She reported some anorexia and constipation, but no fevers, nausea, vomiting, chest pain, shortness of breath, rashes, GU symptoms, headache, polyuria, polydipsia, or leg swelling. She had never had anything like this in her past. Past medical history is unremarkable. Past surgical history includes a C-section for delivery. And in medicines, allergies, she just took multivitamins, mostly vitamin B12 and iron, as it was presumed to be a vitamin deficiency by multiple physicians. And she has no allergy history. Family history is non-contributory, and socioeconomic status is she belongs to a lower middle class, lives in Pakistan with her family, including her husband and 2 children, no occupational and environmental exposures. And that's the end of aliquot 2.
Yeah, that's so great. Julia, I was gonna ask you a question. Is like, can you think of the overlap between like electrolytes and bone pain, or disorders that can affect both the kidney and the bone and cause bone pain?
I was thinking about hyperparathyroidism here. Yeah, that was something.
Yeah, that's what I was thinking about as well. Could there be like, is there like a hyperparathyroidism, for example, causing bone pain, or is there like an invasion of the bone, right? Could there be like, this is not maybe potentially not in the right age group, but if you're a little bit older, you would consider like multiple myeloma invading the bone, for example. You want to look for like lesions themselves, or could there just be like severe malnutrition causing like low vitamin D, causing like rickets, for example, causing like severe pain? But I think we won't get there until we get to the labs. But we'll keep that in the back of our mind as we think through this, because this could be just the result of malabsorption, right, or malnutrition. Because we hear significant weight loss, we want to find out like why this patient is losing this much weight. Is this a catabolic state, or is she like having decreased PO intake, or is she malabsorbing? Because these are the main mechanisms for patients to lose like significant weight. I don't think I could take the diagnostic value here any further. Any other thoughts you had, Julia, from this aliquot?
I was just additionally thinking about, yeah, as you mentioned about any like, I'm really very curious for the lab, especially if they're like how the calcium labs are, and also thinking about even like any paraneoplastic, yeah, phenomenon going on. There could be a PTH-related peptide that can also be at play here and leading to like decrease or yeah. Deliberation of calcium from the bone and distracting it. So I think many possibilities on board, but I feel this patient is really ill and something systemic is going on here. Um, so I'm very excited how the case evolves. Please, Ellie, take us further.
Let me present aliquot 3. And I will start with the vital signs. Vital signs were temperature was 99, blood pressure was 100 by 60. She has multiple times. She was hypertensive multiple times when she checked the blood pressure at home, and heart rate was 72 beats per minute. Respiratory rate was 17 beats per minute, and breaths per minute, and oxygen saturation was 98%, and BMI was 20 kilogram per meter square. On general examination, she was thin, alert, but weak. and was carried into clinic by her brother. Head and neck showed firm swelling over the left maxilla, mild proptosis on that side, no palpable cervical lymphadenopathy, thyromegaly or masses appreciated. On cardiac examination, regular rate and rhythm with no added sounds, rubs or gallops. And on respiratory system examination, it was clear to auscultation bilaterally. On GI examination, she had mild distension, but no rebound or guarding. And musculoskeletal system showed diffuse tenderness to palpation over all the extremities, though no associated swelling or redness was present. And she was unable to rise from a seated position without assistance. Uh, and on neurological system examination, she had intact cessation to light touch throat. Strength was 4 by 5 in the end, in and the shoulders, hips, and knees, and otherwise 5 by 5. And reflexes were 2 plus, and symmetric throat. And she had normal cerebellar testing, and we were unable to access the gate. On dermatological examination, it was unremarkable. Laboratory, let me present you the laboratory investigations. White blood cell count and platelets were normal. Hemoglobin was 11.6 with normal mean corpuscular volume. Sodium was 131. Potassium was 4.4. Chloride was 107. Carbon dioxide normal. Blood urea nitrogen was 30 and creatinine was 0.7. Calcium was 11.6 and phosphate was 3.5. She had a total protein of 6.2 with albumin 4.2, and AST was 40, ALT was 45, alkaline phosphatase was 582, normally less than 135 in our labs. So coagulation profile was unremarkable. Our erythrocyte sedimentation rate was 49, like mildly elevated, and TSH and HbA1c was normal. Urine analysis without hematuria, pyuria, or proteinuria. And that's the end of aliquot 3. Anything
Thank you so.
which would you?
Yeah, thank you so much.
Anything?
And sorry, go ahead.
Yes.
I just wanted to ask you how many aliquots total there are?
It's total of 6 aliquots.
Okay. And do you think we should stop now for a discussion? Because we could do breakout rooms now for a few minutes and then come back.
If you want to discuss some of the lab values, then we can stop here. Otherwise, I should.
Okay. I'm gonna do breakout rooms for like 1 to 2 minutes because this is so much information, so people can digest it and think about it. Just when I make the breakout rooms, you won't be able to see the screen, so just make note of we have a low BMI, we have firm swelling of the maxilla with proptosis on that side. No lymphadenopathy. We have some proximal weakness in the shoulders, hips, and knees, just like the song. And the labs, the calcium is 11.6, elevated ESR, markedly elevated alk phos as well. And we'll do maybe 2 minutes and then we'll take your point of view. So let me pause the recording. Welcome back, everyone. So just wanted to see if somebody wanted to share what they talked about in their breakout room and what you thought about the labs or the swelling. So I don't know, Anmol, if you're able to unmute, just share a little bit of what your group talked about.
Yes, we are right there with you. I think the first thing that strikes out to us is there is some sort of inflammation going on inside the body, be it in the form of some underlying undiagnosed malignancy. I'm not sure about any underlying chronic inflammation which can present like that, infection which can present like that. But there is some inflammation inside the body. And I think if the main, if there's so much information going on, it will be key to actually solve the problem one by one. So the next step will be to dissect the hypercalcemia. Why did that happen? To get the 25 hydroxy vitamin D PTH And I think to go with that next, if we expect that parathyroid hormone to be low with hypercalcemia, if it is not, then we suspect from on primary hyperparathyroidism side. So I think that is where I am right now, to dissect this hypercalcemia, and definitely the ALP is most likely coming from the bones only. We can get the GGT to confirm that. That is what I'm thinking right now.
Yeah, wonderful. Well, anybody else want to share their thoughts? And if not, Julia, if you want, in the meantime, you can. What are you thinking about the face, the left facial swelling, or how are you thinking about that?
That is so interesting, right? Well, I feel one comment I loved from, or well, to first of all, I think the swelling in the facial area, I was thinking about like more a tumor-like lesion, and if that could, I think I've read something also about like brown tumors and hyperparathyroidism, if that could be mistaken, be something like that. That was just an association I had. But yeah, besides, I'm with Anmol, so thinking we really have to understand the hypocalcemia and the PTH related peptide, um, and thinking about where is it coming from. So it could still be like primary hyperparathyroidism, and I would probably not expect it to be from like perineoplasty because it has been the syndrome has been going on for quite a while and is so severe right now. But like any tumor-related peptide, I kind of would expect it to progress a little bit faster, I guess. And also what's interesting here in the pertinent negative, I feel, is the normal creatinine and the low phosphate is in line with that. But yeah, I'm not sure. What do you think about the tumor, Yusuf?
Yeah, so we said there's facial swelling. We're not considering fluid, we're considering infiltration. And what kind of tumor is it? Could it be a tumor that's actually secreting PTHRP, like a squamous cell carcinoma, right? Or is it like a brown tumor, like Mark suggested that idea as a result of the chronic hyperparathyroidism? These are both like really good ideas. And I think we have to pause here at the calcium workup and start considering, is this PTH mediated or non-PTH mediated? Is this PTHRP mediated, like you said? And that will be really helpful. And I think usually if somebody comes in and their calcium is more than 14, then the likelihood ratio that this is a malignancy skyrockets. But if they come in that's less than 14, it could still be a malignancy, but it's not like slam dunk. So usually the number here is it's still like open. The other thing you want to see is like what the calcium level is after hydration. So that will also be interesting to see, like after hydration, where does the patient end up? And like you said, I think it's very important here to check a FOS level, things like that could cause like this weakness presentation. And then we didn't comment on the proximal weakness. I think it's hard to say if it's like actual weakness or a myopathy that we're seeing as a result. But I think we'd get a CTK level and get the electrolytes and then take it from there, depending on the workup or where the workup goes. And then we would get imaging as well of the head and neck. So back to you, Ahmed.
I would like to share an X-ray of water's view of a face. Should I share my screen?
Yes, you can go ahead.
Let me. Can you see my screen?
Yeah, we see the PowerPoint open.
So I would like to show this picture in element number 4, along with the following description. We did her chest X-ray and EKG, both were without abnormality. A CT scan of the face from the base of skull to the thoracic inlet, which showed approximately 6.5 multiplied by 6 multiplied by 6.2 solid and cystic mass in her left maxillary region. It was occupying left maxillary sinus, left ethmoidal sinus, and left nasal cavity. No intraorbital or intracranial extension were present, and however, mass was compressing on retroorbital space and was causing proptosis. And this was her Waters view X-ray showing maxillary sinus opacity. Should I send next aliquot along with it?
Yeah, please. This is really cool. Thank you for sharing, Ahmed.
And we did her vitamin D levels. 25 vitamin D was low at 7.1, and 25 vitamin D mildly low. SPP, SFLC were normal, and urinary calcium was elevated per her oral intake and per our lab cutoffs. And incisional, we did the incisional biopsy of the mass, which revealed the following: lesions showing scattered giant cells, unevenly distributed. Dilated cystic spaces were with areas of hemorrhage were identified in the lesion, and there was no evidence of malignancy. All cultures were negative. And this is the end of the liquid.
Yeah, thank you so much, Ahmed. And do we have the PTH or PTHRP or not yet?
I'll present that in next along with some.
Okay. Any thoughts, Julia, on this aliquot?
I think what is reassuring here is the low levels of vitamin D, probably suppressed by the hypocalcemia, and also like, I mean, still I would be very curious to know about the PTH, but that I think is still in line with like one of our differentials thinking about primary hyperparathyroidism. And besides, what's described here is the cystic mass, and I'm not. I don't know what you think about it. I think I'm not able to make progress with just the morphology of it.
Yeah, I think it's reassuring that it's not like a massive malignancy infiltrating the jaw. I think that's the reassuring part. And there was like some thought, Andrew put it in the chat, is like if this patient has been living with this for years, would that make that less likely to be a malignancy? So I think that's reassuring. That's what I'm taking from that. So I think the problem we were solving before, which is hypercalcemia and facial swelling, we can maybe take that down the list and maybe just solve the problem of hypercalcemia. And we see that the urine calcium is high. I don't know the sensitivity of it, but I think it's high, which is making us think that could there be urinary wasting of calcium? So it's either PTH or PTHRP mediated. So I would want to know more. So back to you, Ahmed.
So, the liquid 6 now. Serum PTH level was 1110, which is way higher. And on renal ultrasound, small non-obstructing renal stones were also present. Radiological investigations of limbs showed these images, and X-rays were showing subperiosteal bone resorption with osteopenia and diffuse bone demineralization. The middle image is also showing subchondral bone resorption. So it's the end of liquid 6, and then I will reveal the diagnosis.
Sounds good. And are you showing us the X-rays or should we discuss now?
We can discuss X-rays. Serum PTH was 1110.
Okay. Well, I think here we're seeing like a markedly elevated PTH, and how do we take it from here? So we're considering could this be a hyperparathyroidism causing this like severe osteopenia / rickets, causing the severe pain, and maybe like a brown tumor in the face, which may have progressed. And many people have put in the chat as well as should we consider like MEN syndrome? So hyperparathyroidism is a part of MEN1 and MEN2A. So MEN1 is pituitary hyperparathyroidism and PIT-PAN-PARA. and pancreas. The MEN2A is panthyroid and pheochromocytoma as well. So these are the two like major syndromes. You would also have to like screen for them. What are the next steps? I think here I would want to, like everybody, some people said we might want to check a vitamin D and or replace it, and then that might worsen the hypercalcemia though. You might also consider doing like a scan for the parathyroid gland, which is the system EB scan, to try to find the parathyroid gland or to find the active lesion. What are you thinking, Julia?
That was a beautiful summary. I don't think I have much to add at this point, Youssef.
Yeah, and
Yeah. No, please
if
go ahead.
anybody has anything else to add, now would be the time before we hear the final diagnosis.
I think I should I should reveal the diagnosis.
Okay, but you can go ahead, Ahmed. Thank you so much for the excellent case so far, by the way.
We also did an ultrasound which revealed an extra thyroidal lesion noted at the lower pole of right lobe of thyroid, measuring 1.7 centimeter by 1.4 centimeter. And then it's the scintigraphic evidence showing the that lesion, lesion which we noted on ultrasound of the neck at the lower pole of thyroid. And the final diagnosis was parathyroid adenoma with brown tumor. The cystic lesion was brown tumor, and we confirmed that on biopsy. It was basically giant cells and cystic species. So the diagnosis parathyroid adenoma with brown tumor. We did the surgery, and after a few minutes after surgery, the parathyroid levels fall to about 200, which confirmed the diagnosis of parathyroid.
Wow, that's really, really fascinating, Ahmed. Thank you so much for the excellent case. Yeah. Any reflections, Julia?
Well, that was a beautiful case. Thank you so much for bringing it. I think I felt the most striking thing I've learned here is really taking the time course into consideration, and that can always help us. And it's also easy to bear that in mind. But besides, it was such an interesting case. I've never seen that in real life before, and it will definitely help me memorize it. So thank you so much for bringing it.
And Ahmed, did there any teaching points you wanted to share on your end, or any reflections you wanted to share?
I think everyone knows about the hyperparathyroidism symptoms. In this case, we basically the patient basically presented to us with the cystic lesion. She was concerned very much about the cystic lesion, not about her weakness. She said that she is having this lesion on her face, which is disturbing her appearance. So we started with this. She used to do multiple physicians and was treated symptomatically. Like everyone thought that it's a dental infection and we need to prescribe antibiotics. But with biopsy and the CT scan, we came to know that it's basically benign. And then we processed her why she's having hypercalcemia. Ultimately, we came to know about hyperparathyroidism with brown tumor. It was my case during when I was rotating in my ward, and I also presented this case in university. So thought that I
Yeah.
should see this all too.
Thank you so much. Yeah, you're welcome to join us again in the future whenever you want. Thank you for the excellent case. Nicola, mic is yours.
What a case. This was amazing. Kudos to the case presenter and kudos to our two great case discussants. So let's walk through these patients once again. So we started with a 36-year-old female with weakness. So we talked about the general approach to weakness, where the first step is always to discern, is this true weakness, meaning muscle weakness, when we would then look for a cause in the sort of neuro axis, looking at, is the cause potentially in the brain, in the spinal cord, in the peripheral nerves, in the neuromuscular junction, or actually the muscle itself. Here the exam is going to be key. If we don't find weakness on exam, it's going to be generalized weakness, also called asthenia, and we actually have to look for the center of gravity, because asthenia is always sort of an accompanying symptom. The second step is to look at the tempo. Is this an acute weakness, or is this a chronic process? Another thing is to look for the localization. For example, if we have lower limb weakness, which we had in this patient, it would be important to assess for issues of the autonomic innervation, such as incontinence, urinary or stool incontinence. Then we also sort of focused in on the lip swelling and the facial swelling. So if we have isolated lip swelling, the causes are going to be either angioedema, so look for an ACE inhibitor in the medication list, or if the C4 complement level is low, you could potentially think of hereditary angioedema. Versus on the other side, it could be histamine related, meaning anaphylaxis or allergy. If we have a swelling which does not involve the lips only, we can think of facial swelling or facial edema. It could be fluid retention versus infiltration. So think about glucosaminoGlycans in hyperthyroidism, which can cause exophthalmos. As for the bone pain, which the patient also presented with, we can sort of think of hyperparathyroidism, which can be originating for an adenoma, or it could be also of paraneoplastic origin, which then mostly secretes PTH-related peptide, which is a PTH-like hormone. It works just like PTH, but it's not our physiological PTH, but it rather gets secreted by malignant cells. Low vitamin D levels, which can cause rickets, multiple myeloma, or cancer causing metastatic disease, and by itself then bone pain. We also touched upon weight loss, which can be, again, roughly divided into a low or a poor per os intake, which has a broad differential, so the patient might not have access to food, or might be neurologically or cognitively impaired, versus a consumptive disease, which are usually chronic, which can be chronic autoimmune diseases, infectious diseases such as tuberculosis or malignancies. Then we found in the labs that our patient has hypercalcemia. And when we see hypercalcemia, we assess the PTH. We assess PTH. We can also assess for PTH-related peptide, and we can assess for vitamin D levels. Those are sort of the two axes which can cause hypercalcemia. So for example, you could have excessive vitamin D intake, or you can get granulomas, which can then also increase the vitamin D levels, and by that causing hypercalcemia. We then tried to sort of find an overlap between hypercalcemia and the bone lesions that we saw on imaging. And there are a few things to keep on your mind. Hyperthyroidism can cause brown tumors, and I think brown tumors is going to be the thing that I will definitely remember for a long time. Well, thinking of this case. So a brown tumor is not a malignant tumor, but it's rather a lesion which occurs due to high osteoclast activity. Another alternative to hyperthyroidism and a brown tumor would be, again, cancer secreting PTH-related peptide causing bone lesions, or rare head and neck cancers can actually also secrete PTH, again causing bone lesions. Our patients then was revealed to also have high urine calcium, which really sort of dials in the PTH or PTH-related peptide cause of hypercalcemia, and we then got high PTH, which again is most likely going to be primary hyperthyroidism, an adenoma. You can very rarely get hyperplasia of the parathyroid gland, or even more rare, you can get cancer of the parathyroid gland, again, also causing secretion of PTH. And in young patients, such as our patient, it would also be important to screen for MEN1 and MEN2A as primary hyperparathyroidism is part of these syndromes. And that will be all from my side.
Thank you so much, Nicola. That was amazing. And while you were presenting teaching points, I also looked up a third hereditary syndrome other than MEN1 and MEN2, and that is the hyperparathyroidism jaw tumor syndrome, which many people put in the chat. But it also has like hyperparathyroidism and a mandibular mass. And I was looking up the pathology here, which said giant cells, and I looked it up that this could be consistent with either a fibroma or a brown tumor. So this could be, in fact, the hyperparathyroidism jaw tumor syndrome. Wouldn't necessarily change the management. You would send the cells to pathology, but they would be at increased risk for hyperparathyroid cancer in the future as well. So just something to know. But never heard about that before. So so much fun and reading. And thank you everyone for joining.
Thank you very much for this opportunity.
Hope to see you soon, Ahmed.
Inshallah, I will present another case soon. Sure.
Thanks for the great discussion, Youssef. See you soon.
See you soon.